is Jennifer Adams. I am the Assistant Dean of our Clinical Curriculum, so oversee all of the LIC training across our different sites. And my task today is to introduce you to the LIC concept and our clinical training across all of our various sites. Since we are small, Steve and I have had a chance to meet before, but could I just have you do quick introductions? Steve, maybe I'll start with you. Let us know which LIC site you'll be teaching at. That'll help me kind of orient this a little bit better also.
Yeah, absolutely. I will be at the entrance clinic for general internal medicine.
Okay, wonderful. Thanks so much. Chris Style, am I saying that correct?
Yeah, it's Stilla. Thanks.
Stilla. Okay.
Yeah, I work in the child health clinic at Children's Hospital.
Fantastic. Okay, thanks so much. Nice to meet you. And then Joseph Smith.
Yes, I'm at Premier Pediatrics in Brighton, obviously teaching pediatrics.
Okay,
Great.
Fantastic. Wonderful. Thank you all for teaching our students and for spending an hour of your time together. With me tonight.
And I'm finishing up my second LIC student. So I've had a lot of experience, but thought I'd join because I don't always know what I'm supposed to be teaching them. So
I love that growth mindset. I've had LIC students for years and feel like I'm always learning something new. Joseph and Steve, are you brand new to the LIC model?
I'm finishing up my first student.
Okay.
This will be my first time.
Okay. So Chris and Joseph, I'm going to ask you to join in and share any of your wisdom as we go through this. If you're like, actually, my experience is different, feel free to jump in. Okay, so let's go. So the necessary CME slides here. Please do claim your CME credit. We will distribute the CME certificates after this session. I'll pause here, scan the QR code. If you wish to, this will allow you to submit your name and your email so that we know how to contact you later for attending the live session. Just give me a thumbs up once you're done with this segment and I'll know it's time for me to move on. Okay, fantastic. So my learning objectives for tonight. What I want to do is make sure that by the end you feel supported and supporting your LIC learner, and hopefully also feel able to enhance your teaching experience through an understanding of what this LIC model is all about. I want to help you feel like you've built a partnership with your LIC student. Ultimately, what I really believe strongly in the LIC model is that, in contrast to the block model where their students are in and out, sort of a revolving door, is that through their longitudinal placement in your clinic, they can add real value to your practice and your experience as a teacher. So let's figure out how to get there. We'll talk a little bit about a plan to approach your first day with your student so that you can set yourself up for a great year together. And then finally, we'll wrap up with just some resources to take sort of the next step and support you as a faculty preceptor. So I'm going to spend a little bit of time just going through the nuts and bolts of how this LIC curriculum comes together. I trained a while ago, and the LIC was not something that was even on the radar then. And so this concept was certainly new to me when I first started learning about this about a decade ago. And so I think that's one of the challenges we face as educators, that this LIC is just not familiar based on our lived experience. So sort of understanding how this comes together ends up being pretty important. So the principles of an LIC basically come together around our core sort of clinical values and how we train a medical student. So at its core, an LIC allows our students to participate in the comprehensive care of patients over time. So this is really in contrast to the block model, where our students are anchored in the specialty in which they're rotating in and the team that they're placed on. So if you think about the way we used to do it, you were placed, for example, on a pediatrics team, and you went wherever that team went, wherever that intern told you to go. And all you did was pediatrics. In contrast, what we do in the LIC model is really put the patient at the center. So the student is learning about the patient, and wherever that patient goes, the student goes and follows their learning that way. They have continuous learning relationships with their patients' clinicians. So the way we set this all up and organize the learning is our students are placed with longitudinal preceptors throughout the year, all of you, and then they attach themselves through their learning, through their experiences with your patients, and develop their their sort of learning agenda around all of that. We all know that our patients are not siloed in care. I'm also a general internist. And so my patient doesn't come to me and say, I've got internal medicine problems today. They might have a knee problem and I need to send them to orthopedics. So the patient or the student can follow that patient and continue their learning there. Still a human being, it's still a patient. They met them with me in internal medicine, but they can transition there and follow them throughout their patient course that way. So through this model, our students meet the majority of their core clinical competencies across multiple specialties simultaneously. So how does this actually kind of come together? If you think about the traditional block model, that's what's demonstrated at the top here. Our students might have started a block of internal medicine. In our medical school previously, that was 8 weeks long. So they started day one, all day long, every day, they did internal medicine. At the end of that, they took a test. And then they went on to pediatrics, and then they might have gone on to psychiatry and so forth until the end of the year. And then they sat down and they had to do something big, like take step 2, and then move on to their specialty rotations. Some of the challenges inherent in that is it's really hard, if you think about it, to do some of the integrated learning. How does internal medicine actually connect to surgery? There's quite a bit of overlap, as we all know, in those clinical presentations. It's also really hard for our students to think all the way back to the beginning. For internal medicine, like, what did I learn there? How does that apply here, when they have to sit down and take those comprehensive tests very tangibly, but also become a really comprehensively trained clinician, which is our ultimate goal. So in contrast, in the LIC model, our students are enrolled in each of the core specialties all year long. So they take a clerkship in internal medicine that starts day one and ends at the end of the year. Simultaneously, they're taking pediatrics, psychiatry, and so forth, matched with longitudinal preceptors, all of you, all year long. They don't see you every day, but they see you once a week or once every other week and are doing that learning on a continuous basis all year long. So how does this actually come together practically in a given week? This is an example of what a student's schedule might look like. They might start with pediatrics on a Monday morning. So let's say they're with Chris or Joseph, and then they come hang out with Steve in the afternoon in internal medicine. Let's say on pediatrics, you have a sick kiddo that you actually send to the ER for evaluation. So maybe after internal medicine, this student is like, I'm going to go check on that kiddo in the ER. They get there right as that kid's being admitted to the hospital, so they can round on that kid or go visit them in the hospital. Then on Tuesday morning, before they go to family medicine clinic, we would expect them to go round on that patient in the hospital and figure out what's going on. So they'll connect with a hospitalist, they'll connect with the inpatient team, participate in the inpatient care to whatever degree possible, and then head out to family medicine. Hopefully they text their pediatrician preceptor and give you an update. That's sort of the continuity of care that's happening over time. Then they go into OBGYN. On Wednesday morning, the student has extended learning time. And what this is not free time. We sometimes have to clarify that for our students, but this is where they're supposed to have unstructured time to follow their continuity patients, to work on projects, to sort of independently follow their panel. So they may look at their schedule and say, oh, I also have one of my internal medicine patients who's supposed to go to cardiology that day. So they may round again on their kiddo who's in the hospital and then head off to cardiology to see that patient back in time to meet with their cohort of learners. So all the students in that LIC for their learning seminar. So this is when they are gathered together in their learning community. The way we've structured their sort of formal didactic curriculum is in a team-based learning format. So kind of trying to mirror the type of learning that they're doing in the LIC as a whole. Case-based, so patient-centered, integrated. So for example, I actually taught TBL this afternoon. I taught a couple of anemia cases. That intentionally, the patient starts in the ED, gets admitted to the ICU, GI comes in, surgery comes in. We're trying to make these cases real to life, but also illustrating the fact that the differentials are broad. All these specialties come together to take care of a patient. It's not a specialty silo. So that's sort of a demonstration of how this week might come together over the course of the week. By the end of the week, they've touched sort of all their specialties and then start the process over. In addition to the longitudinal preceptors, our students engage in what we call inpatient immersions. So with their 5 core specialties listed over here on the right side of the slide, they spend sort of concentrated inpatient time. So I always start by explaining what these are not before I describe what they are. These are not mini clerkships. So there's this tendency to think like, oh, great. So the student's coming to me on internal medicine for 2 weeks. That used to be 8 weeks. So can I really cram all of an inpatient medicine rotation into 2 weeks? The answer is of course not. So the objectives are different. And we want to be really clear about that so we don't have residents or attendings coming to me, sending me emails like, hey, Jen, I'm really concerned about this student. They were only here for 2 weeks and now they're done. I don't think they've learned everything they were supposed to on internal medicine. Your curriculum doesn't work. This is part of a much larger picture. Our goals are to expose them to sort of the way the ward works, the skills, the content, so that when they have that patient who's admitted to the ward later on as part of their cohort, they can show up and reasonably participate in care. It's not going to work awesome if they've been following a longitudinal OB patient, for example, but have never been to labor and delivery, for them to show up and try to deliver that baby. Works much better if they've been there, spent a little bit of concentrated time, understand the process of a delivery, then they can jump right in and participate in a meaningful way. So we want them to sort of have that orientation to the clinical space. We want them to spend a little bit of time focused on the acutely ill. We know the cadence of inpatient care is really different. Events occur over hours as opposed to over days, over weeks, as they do in the outpatient setting. So they need to be there all day, maybe for 2 days, 3 days in a row, a couple weeks in a row, to really see how inpatient care, acute care, evolves for a patient, which is really different than the outpatient setting. They get a lot of practice in admissions and discharges, oral presentations, notes. They get to work sort of face-to-face with consultants. They get to practice with inpatient teams. And this also gives them the chance to kind of explore what that type of career would be like. And then finally, I'm going to come to the patient panel. These are the 3 components that I see critical to the LIC: the longitudinal exposure with their preceptors, the inpatient immersions, and then finally the patient panel. So our students, we expect them with their given patients to serve as the care providers, the advocates, the navigators for their patients throughout the LIC. They should attend all their visits, their admissions, their procedures, their deliveries, whatever it is. We try to get them there because they are really core. Their learning, again, goes back to the patient being at the center of that. We ask them to develop a cohort of patients. It's not huge. It's about 15 patients, but over the course of the year, they should be there for that patient. They should follow them over time, over care venues throughout the year. So I'm going to pause here to answer Chris's questions. So we should tell them to feel free to read and learn about their primary care patients during the extended learning time. Absolutely. So I'm going to talk a little bit more about that, Chris, at the end, but I think that actually is one of the ways that our preceptors could be most effective is at the end of your session to be like, hey, we saw this patient with such and such condition. I saw that as a learning gap, or I don't like, my favorite thing is like, I didn't actually know anything about this. I want you to go look it up and come back and teach me next week. They have time for that. And I think that's the best way to push their edge in learning.
That's
Give
great.
them assignment every single time.
I guess sort of, it's funny because I think about them having a lot of continuity with me, but not with patients. And they, typically they'll have 4 or 5 patients that they do see continuously. And I think I'm not taking advantage of that to the extent I could.
Yeah, absolutely. Tap into that. Wonderful. All right. So I have this up here not to show you all the details, but just to give you a sense of what their requirements are. The student is in charge of this, not the preceptor. So this is not for you to own or memorize, but gives you a sense of sort of the scope or the variability of the patients they are required to obtain in their panel. So the idea here is that it's broad. They need a couple medicine patients, a couple peds, etc. This is on them. But if you want to ask them like, hey, how's your cohort going? Do you need any more peds patients? Here's a good peds patient. I think that's another way that we can support our students. Okay, a couple more words about team-based learning. This is the format we've chosen to choose our students in their didactic sessions or their seminar time. So we are really trying to capitalize on the fact that we have our students in small groups. So our students, and I'll get to this in a minute, but are divided. We have about 190 students in our curriculum, but they are divided in this clerkship year into 16, what I call learning communities spread across our systems. And so this allows us really to capitalize on this small group interactive environment for teaching. We want to be supportive and we want to push them in their clinical reasoning. So they're expected to read the material ahead of time and then show up and work through cases together. So these are a couple of pictures of the students working through a case together. What we're trying to do is foster a growth mindset. Nobody comes to the table understanding everything about this case, just like we do in the clinic or in the hospital. We're going to learn together. We're going to teach each other. And this allows us, because we have the whole year with our students, to start with pretty easy cases, easy for them, and then move to much more complicated, difficult cases. We also are able to integrate some of the other pillars of our curriculum. So throughout the clerkships, we are also trying to reinforce some of the basic science and push their knowledge of that. So trying to like remind them, hey, you learned some, microbiology. How are we going to apply that to pharmacology? Why are you picking these antibiotics? Do you remember like those bacteria you were taught? Let's bring that back. And then also talking to them about health and society. So that's kind of the health system science, ethics, professionalism, social determinants of health. We can write cases that bring all that to the forefront. So those are the nuts and bolts. Let me pause there to see if there are any other questions about the structure. And then I'm going to talk a little bit about the rationale for the why we went to LICs and some of the science, just a little bit of the educational science behind choosing this method for our School of Medicine.
I do have a question I'd like to ask. In terms of best ways to promote continuity for the LIC student with that patient panel, is this something where they develop a list in the medical record and they periodically check it? Is it something where us as the preceptor, the best thing we can do is when there's a change in that patient's care, condition, et cetera, we notify them? Are they included in the EPIC team? Is there something else I'm not even thinking of? How can we best support them with that?
I love that question. So that's fantastic. And I think it depends a little bit on your healthcare system. So at university, at Children's, it's a little bit easier. We do expect the students to manage this. This is on them. So in systems where there's a great EMR and they're sort of in the system, they're doing their inpatient stuff, their outpatient stuff, they've got multiple preceptors in the system, it's easier. So they can put them on their care team, or they can add themselves to their care team. They can put them on patient lists. They can get like those flags or those notifications when the patient shows up in the ER or is admitted. So that's easier. It's on them. If the patient is at Brighton Pediatrics, for example, it's a little bit harder. But if they are connected, I don't know if like the patients at Brighton tend to get admitted to Children's North, or if there's like a typical hospital they go to, but I think we can try to be intentional about supporting them. I do not expect our preceptors to keep like a mental list of every patient the student has ever seen with you. That's crazy. But I think we can support our students when it sort of occurs to us like, oh, wait, I know this patient has seen my student. You'll get sort of into this rhythm where you're like, this patient has now seen my student 3 times and oh my gosh, they're admitted. I'm going to forward the admit notice to them or text them. I think that's one of the things we'll get to at the end about sort of how to set up expectations with your students, kind of coming up with that strategy with them. How am I going to tell them? With the understanding also that if they have a shelf exam the next day, they can't go see that patient. If they're on their inpatient surgery immersion, they also can't go see that patient. So it's the way I always frame it to my students. This is an opportunity. I'd never an expectation, but I'd love for you to see my patients. And if it works, let me help you. But this is really on the student to sort of figure out how it's going to work within their learning world. I also always tell our preceptors, remember, you're but one preceptor. They've got 6 others who are also giving them learning assignments and have all their panel. And try to work with them on how to support the learning. I don't know, Chris and Joseph, if you have other strategies or other things that you found to be successful in this in your own practice.
I think it was helpful in the beginning for me to start thinking through some of my more complicated patients who see a lot of specialists at Children's Hospital. And then right up in the beginning, we sort of selected one, and we actually talked to this patient's mother and said, would you mind coming and doing your visits Monday morning so that my student can follow you longitudinally? And then he ended up having a procedure at Children's and she was able to follow that. But I think really identifying someone early on, someone who comes in frequently, so it's kind of an easier person to get them connected, I think is very, very helpful. It's too easy, I think, for time to kind of go by, and then it's like, oh, we really haven't gotten you someone that you can really follow. So that's something I think I'm really going to focus on within the first month, getting someone connected.
Yeah,
I love that.
We have a lot of babies and toddlers that come in for well visits, and so one of the first things that I did with both of my LIC students who didn't have really any experience with kids before in their life is, to focus on child development and trying to say, okay, these are 4-month-olds and they're all normal, but they're different from each other in these ways and that kind of thing. And so by focusing on sort of developmental trajectory and then seeing the same kids time after time, I think, that was good. And we focused a lot on that stuff. So
those are both great strategies. I think also, like, in addition to what you're doing, Joseph, if I see a complicated patient on my schedule, to be really proactive ahead of time and be like, I'm going to have you see this patient and this patient. These others, like, they see me once a year, just like for like their routine checkup on their hypertension. Like, it's fine to see them once, but these patients are the high yield ones. Go after them. Okay, great. All right. So I'm often asked, why did you blow up the curriculum? It was like, we all trained in the old way, seemed like it was fine. So why this huge change? And so my response to that is, I think the clinical environment around us has changed dramatically in the last 20 years. So our students have been sort of bystanders to this. There are increased clinical pressures on time, on revenue, on productivity. In the inpatient world, especially where we have residents, they are all shift-based now, duty hours, all of these factors and many more come together to create an outcome in which our students have moved from being very actively involved in patient care, writing notes, part of the team overnight, working there, like very much engaged authentically in patient care, to being sort of relegated to a very much observer, bystander kind of role. And so all of these challenges have led many in the sort of education world to think about how can we do it better for our students. So I love this quote from an LIC student. The main strength of my LIC is its implicit assumption in its structure and execution that students are capable of doing meaningful, substantive work. And so I come back to that often, like what we want to do for our students is create a meaningful, real role for them where they can be participants instead of bystanders. So many publications, both in the academic and also lay press, about how much medicine is changing around us, and many calls for reform. So we are part, I think, of both a larger movement, but also leaders in this. The University of Colorado is the first medical school to take a very traditional curriculum and flip it to an all LIC. There are other schools out there that are starting up with all LICs, new medical schools, but we're the first in this grand experiment to really turn something over completely, which is super exciting. And I think takes really this enormous village of our faculty. So I just will continue to find opportunities to express my gratitude to all of you as faculty for coming along with us on this journey. But I also want to hope to sort of convey some of the excitement around what we're doing and share in that with you. So some of the science that is behind our belief in this model. I won't spend a ton of time here, but I think this underpins why we know this model to work a little bit better than the block clerkship model. So I won't spend a ton of time here, but I think understanding this is critical to understanding the LIC. So this comes from cognitive psychology, the concept of space learning or spaced review. So if you will, this pink line here represents sort of what I think about as a block clerkship. So if we take a student at the end of, we'll start back with that log graph we had, internal medicine clerkship. a student theoretically can master quickly. They're smart kids, right? They come to us, they can master the material very quickly in a block clerkship and reach close to 100% retention of the material. They can sit down and cram for a test, basically, and do well. But then what happens is they move on to their pediatrics clerkship or whatever comes next and fall quickly onto this thing that's known as the forgetting curve. And so without repetition, without spacing, without any sort of intentional effort, the student, really anyone, will quickly forget. And we see a degradation in that knowledge. And so by the end of the year, if that's way out here, unfortunately, when it's time to move on to their next phase of their training, their acting internships, step 2, very tangibly, they basically have to start over. They don't remember anything from that initial clerkship if you sit down and ask them cold to take a knowledge-based test. Alternatively, what we want them to be on is what we call the learning curve. And this sort of replicates what we've created in an LIC. So at the beginning, it's hard. And I think we experience this in the LIC. It is much more satisfying as a learner to see a rapid accumulation of knowledge. You feel accomplished. This is satisfying. In the LIC, it is slow. And this journey in the beginning of the year feels tough because they only come to see you every once in a while. So the first time they're there and they only learn a little, and then maybe they forget a little bit, but then they're back the next week, the next month, then the next week after that, the next month after that, and things are reviewed. They build on it, they build on it, they review it, and they're on this curve where over time, they end up exactly where our student was in the block clerkship. It just takes a lot longer to get there, but it's sustained. And if you think about doing this in every single clerkship, instead of being in a block model where everything is forgotten, except for the most recent clerkship, we have a student who has 7 clerkships fully retained. So this is sort of the spacing concept around an LIC model. The other concept, let me talk about the J curve. This may be something that resonates. This is something I talk to the students about constantly. It's sort of how tough this is in the beginning. It does not feel good to go back to your preceptor multiple times in a row and feel like you're not making progress. And in fact, feel like I was better at the end of my first year where I knew all these facts, all these basic science facts. And now I'm in this clinical space and those aren't that fresh anymore. And all these people keep quizzing me and I keep going into things and I'm not getting it. Students feel really frustrated in the LIC in those first couple of months. So I talk a lot about this J curve where there is a huge investment in learning in the beginning. People feel like they're getting worse. And I think actually as faculty, I sometimes observe our students getting worse, but there's this sweet spot. It's a couple months in, maybe even halfway through the year. I think where students are on this curve varies, but almost inevitably, there are a few students who are the exception, but inevitably for most students, they will hit the bottom of the curve and then start their upward trajectory. So it is really in the second half of the year where we see the magic of the LIC. But then this curve up on the second half is steep and it's wonderful. Like this is where the students start to benefit from the LIC and you see the connections being made and you see them really start to thrive in their environments. They're comfortable. They're putting all the pieces together and the LIC model starts to work. But there is this investment in the beginning, which can be really a struggle for our students. And this is what I hear from faculty too, who are like, this isn't working. This isn't going well. I think my student's failing. Am I doing something wrong? So I like to sort of highlight this, that it relates to this. If I go back here, it relates to how slow this initial slope of the curve is. Have either of you experienced this slow start to the year? Not so much.
Yeah, pretty slow. I mean, I don't know. I've had one okay student and one great student, so it's hard to compare.
It's hard.
So.
I've had one great student who was very motivated early on, so I feel like she learned faster. It was me who was doing the J curve.
You were on the J curve. Okay,
Yeah,
that applies to students and faculty. Keep this in mind for the more typical student. I'm glad you've both had a great students. We do have really good students. All right. The other piece of science that I want to bring in here is what we call interleaving. So the concept here is, quite obviously, this looks to be like exactly what we see when we turn that when we turn that initial graph on its side. So we have block clerkships across the top, and then we have an LIC model here. The way I think about this more is in terms of like a concept though. So if we had a student learn about something like abdominal pain on surgery, and then go many, many months and learn about abdominal pain on, like, let's say OBGYN, and then go many, many months and learn about it on pediatrics, they would learn differential diagnoses. They would learn different workups, different presentations, different management approaches. But the reality is, if we put this all together, abdominal pain is overlapping in all these domains. Same organs, same pathology. There's subtle differences here. So what we can actually do is, if we have a student in the same week who goes to surgery and sees a patient with abdominal pain, and then goes to OBGYN and sees a different patient with abdominal pain, and then in pediatrics, the student's able to make these connections much more readily, and then builds a schema in their brain of what is abdominal pain across everything, and is able to think much more clearly through what we're trying to teach, which is clinical reasoning, and build these memories that actually stick in the way we want them to think about it, in terms of being an experienced and seasoned clinician. This is what we do as somebody who's been in practice for a very long time and has seen a lot of cases. We can build this much, much faster if we are interleaving and mixing things up, challenging our students to do the hard work up front, rather than keeping everything in these silos where it's organized, but that's not actually how it occurs in the real world. So what interleaving has been shown to do is strengthen these memory associations. So we're forcing the brain to retrieve different things at different times, bringing things constantly back into the short-term memory where it used to be stored way back here, and repeating these tasks, but making it a little bit different each time, which has been shown to enhance learning. So these, I think, are the two core pieces of educational science to think about when we think about how we set up the LIC. So from here, let me sort of explain how this has played out into like actual practice. So enough about the theory and how this plays out in some psychology lab. Let's think about how this actually plays out with our students. So I think about the important outcomes, both in terms of our students. There's a lot of data here about how this plays out in terms of their academic achievement and some of their non-cognitive outcomes. But I also like to think beyond that. What is important to our faculty? What's important to our patients, healthcare systems, and ultimately communities? So back to our patients, what we are trying to create here, sort of at its most foundational, is a reframing of our student role. What we want to be able to do is, with this longitudinal relationship with all of you, create a system where our students can share responsibility for patient care with their preceptor. So I encourage you to think about that when you have a student who's with you. As you move through the year, how can you build that trust with them so that you see them, to whatever degree possible, and this will grow throughout the year, as a partner in that patient's care? Make them a longitudinal team member, a care provider, a navigator, an advocate. The students want to do anything. So what may feel to you like a menial task, sitting on the phone for 20 minutes with the insurance company, that's great learning for them. Not just learning about the medicine they're trying to get, but about the healthcare system, right? The health and society stuff that we're trying to teach them. They're being an advocate for their patient. We call that like street level bureaucracy. They are learning so much from what you would consider a god-awful task, right? Kind of the bane of our existence. This is what students want to do. They want to be helpful. They want to be real and authentic in what they're doing. The longer you work with them, the more you learn to trust them. They should earn your trust. Don't give it to them day one, but over time, you learn to trust them. This is how they develop their holistic approach to patient care and their individual responsibility to patients. So how does this actually play out in the real world? This was a study done at UCSF where they've had LIC a lot longer than us. They did a time study of students. If what we want is for them to be authentically engaged in care, you can look at that as this light gray section of the pie here. What we don't want them to be doing is spending a lot of time just watching others. So they watched students and found in the block model, students spent about 41% in this kind of light blue color, just watching others, kind of standing around passively. The light gray color, when they were authentically doing real work with patients, about a quarter of the time. It's really flipped in the LIC model. 56% of their time spent engaged with patients, one-on-one, doing the work of learning, of doctoring with supervision, only 20% of their time spent shadowing. So it is these relationships that you are building with your student that enables this to work. In terms of academic outcomes, I won't spend a ton of time here, but just know the data is there that our students do academically well. This has been shown in the literature across the country, really across the world, and we've seen the same thing here at CU. The academic outcomes are actually a little bit better here in terms of shelf exams in particular, and our LIC students compared to our block students. People often ask me about the match. So we've now had close to a decade worth of students go from LICs into the match. And as you can see, the column on the left here is our highest ranked special or match specialties, I guess I should say, from the LIC. This is identical to what the CU School of Medicine students do in general. The bigger fields are the more popular ones, but we've had students match successfully really into every single subspecialty at this point. So our students are doing well in the match. This doesn't pigeonhole them or limit any of their specialty options, but I do think amongst having that long-term exposure and opportunity in some of our more generalist fields really allows that opportunity to shine. What I find more compelling than the academic outcomes, honestly, is what I call the non-cognitive outcomes. So what has been demonstrated, again, nationally and locally with our own students, is that LIC students compared to their block clerkship peers have increased measures of patient-centeredness and empathy. And so when I think about training a doctor, I want them to be smart. I want them to be capable. I want to be able to measure that on some sort of test. But once I've been able to show that, I want them to have these skills. This is what I think is most important when developing a curricular model. So this is our data from a randomized trial that was done at Harvard Medical School in one of the very early LICs. So the way they set this up is they had a bunch of students who wanted to enroll in the LIC, and they randomized them. Half of them who wanted to do it, so getting rid of the selection bias, got to do the LIC. The other half got randomized to blocks. At the beginning of their clerkships, they had equal measures on a validated scale of patient-centeredness. At the end of the LIC, a significantly higher measure amongst our LIC students of patient-centeredness. What is really striking and important here is that 6 years post-graduation, this difference persists. So when you think about that, a student who might finish their LIC sort of seeped in this like learning environment, we hope to see a difference. But then they go back to their fourth year, mix in with all of the other specialty cultures of acting internships, and then they go on to residency, wherever they're going to go, and we lose track of them, right? We no longer have that ability to shape their learning environment. So what you'd expect here is like, yeah, we had an impact, but that diminishes over time. That didn't happen here. So whatever this intervention was in the LIC, what this suggests is that this had a lasting impact. So it was this study and others since then that have replicated this that was really the why at CU for us to decide to move to an all LIC curriculum. If we can create equally capable academic physicians at the end of our curriculum who are more patient-centered and more empathetic, it really kind of flipped the question as to how could we not choose a model that would allow us to achieve these outcomes. So this is what I want to sort of emphasize in terms of these student outcomes. Let me spend a few minutes talking about faculty outcomes. You all are faculty. I know you're busy. I know there are huge time pressures. There are a ton of other competing demands on your time. You're facing pressures related to cost, access, RVUs, you name it. Taking on a student is an extra ask. So thank you. What the data would suggest, including studies we've done here, is that taking on a student, and hopefully this resonates, leads to an increase in your personal satisfaction, leads to a community of practice, you're surrounded by other educators, there's value there, and that we really can demonstrate a contribution of that student to your clinical care. This is one of the studies we've done here at CU. So this was a study that we did in the year after we switched from all block model at Denver Health, which is one of our affiliate hospitals, to an all LIC at Denver Health. And we just surveyed the preceptors and asked them a bunch of questions, like reflecting back when you did blocks to how it is now. Tell us your thoughts. 85% of those faculty were satisfied with the LIC. Importantly, 57% reported an overall improvement of their job satisfaction. So having a student a half day a week led to a higher job satisfaction, which is striking to me. And I think speaks to the intrinsic value that we all get, the reward from teaching, interacting with the student, sharing in our profession, building that relationship, the mentorship, et cetera. Higher job satisfaction. 94% liked it better than teaching in a block model. This also motivated our change. We need preceptors, and if we can make you happier with a different model, we'll do it. 86% returned the following year to teach. So when I think about, as a curricular leader, I need preceptors. How can I get them? The LIC to me makes sense. These are just a couple of some of my most favorite quotes about the value of our faculty and what the students say about them. I want you to know how big your impact is on these students' lives and their careers. They say our faculty is the strength, the best thing about the LIC. So your impact as mentors, as role models, as teachers, is just immeasurable. I can't do this without your presence and your commitment to our program. So they see you, they appreciate you. They're, in the words of the student, blown away by how hard you are working to ensure the immaculate care for your patients. So I don't know what more I can say that they haven't said here. So this just gives me yet another opportunity to say thank you for your teaching. A few words about our patients. So one of the other questions I get, or concerns I get when I approach people about teaching, is like, well, I want to teach, that sounds fun, but my patients don't want to see a student. So this was something I also was interested in looking into. And this was a study we did also at Denver Health, interviewing patients, hey, what was it like to have a student with you? Because my personal experience was exactly the opposite. My patients love my LIC students, love them, to the point where they're like, well, where's your student, Dr. Adams? Well, we've been working together for 2 decades. I'm still here, even though my student isn't today. And in fact, I think that's really what we saw here. So in this qualitative study, our patients really valued their therapeutic alliance with their LIC students. They thought their patient experience and their health outcomes were better. They told me all about the problems with our healthcare system at Denver Health, but they thought their students really helped mitigate some of that. They saw their students bridging some of the gaps between all of their different care providers and helping them navigate the system, and really experienced pretty profound loss when their student completed the year, even though their doctors were persisting with them. I love this quote. He snuck in to see me in the ER. That made me feel like I mattered. I think our patients often feel so lost in our healthcare system, and a student who can make them feel like they matter is just solid gold. This was another study that was done at the Minnesota VA. What these researchers did was actually randomize patients who had, or not randomized, sort of case control, match patients who were matched with an LIC student to patients who did not have an LIC student, but were matched based on disease severity index, which is something the VA does. And then they surveyed these patients after the completion of the year and found that patients attached to a provider who had an LIC student, so patients with an LIC student, reported greater satisfaction with their PCP in terms of their knowledge of their health history, their explanations, and thought their PCPs were more likely to be looking out for their best interests. And then the most important finding here that I'll just highlight is this huge difference in patient satisfaction scores. So providers who had an LIC student, 65% selected the top category for patient satisfaction versus just 43% in those who didn't have an LIC student. So I think this is a pretty profound and remarkable finding here related to patient satisfaction and the positive impact a student can have. The last thought I have related to outcomes is this somewhat new horizon that I've been thinking increasingly about, and the importance of our LIC students Chris, thank you for being here. Appreciate you. Sign off whenever you need to. The importance that our LICs may have in terms of thinking forward to community outcomes. Both rural and urban communities are challenged by disparities. There is increasing evidence that an LIC as a formative educational experience leads to very high retention and recruitment, even after GME training. So the student goes off to do their residency training, but is quite likely to return to that community where they did their LIC or one like it. And this has been very well demonstrated in the rural literature, and we're starting to demonstrate this in urban communities as well. So another compelling reason, like, we need a workforce that's committed to our patient populations and kind of growing our students up in this environment, getting them sort of acclimated and really invested in this patient population as a formative learning experience, I think can have really profound outcomes for our students. Okay. I am going to spend the last 10 minutes talking a little bit more concretely about what our curriculum looks like and setting you up for your first day. Any questions about those outcomes before we do that and move into a little bit more of sort of practical tips for working with your student? Okay. So this is just a quick sort of transition slide to let you know that our transition to all LIC model, I mentioned that we were one of the first schools in the country to dabble in this and the first to convert to an all LIC model. However, I like to mention that this isn't just this wild leap of faith. We actually have been working and building these LIC models for quite a long time, starting in 2011 and building towards this. So it's actually been sort of an accumulation of evidence and experience that has led us here. This is an overview of our 4-year curriculum. So I want to sort of place you into context. Our students spend a year in what we call our Plains curriculum, sort of focused on basic science before they come to the LICs. The LICs now are placed in the 2nd year, which is a shift from what most of us trained in, with 3rd year being the clerkship year. The 3rd year is now the 2nd year in terms of clerkships. And then students transition to their what is now the 3rd year, where they're doing advanced science and individualized focus of their education. So this is where they're doing advanced internships, formerly known as sub-Is, and electives. So this is sort of, I mentioned our learning community spread out across the state and across healthcare systems. You can place yourself here in this model, but we have our community sort of spread out with intention. We want our students to be embedded in a system where they can have a set cohort of preceptors and hopefully sort of coalesce around a hospital where they can have easy interactions with patients who are admitted in and out of the system, referrals to specialists, and so forth. So this is sort of how the whole curriculum comes together. I wanted to talk just a little bit about who your student's LIC team is. You are the preceptor. So I think about preceptors as being their clinical teacher first and foremost, but you'll become so much more. Their mentor, their coach, their advisor. In addition to doing all of that, we'll ask for periodic written assessments. These are critical for grading. The LIC director is someone you'll interface with quite a bit. This is the person who's in charge of the student's trajectory over time. They organize the student's curriculum. They oversee every individual student's progress throughout their entire year and meet with our students regularly to sort of keep the big picture in mind. Remember, your student has you plus 6 more, plus all their immersion and other stuff. So they're keeping all of that organized for each individual student. We also have LIC liaisons. I think about these as being specialty site directors, kind of like the old clerkship director, but now it's a little bit different because I've got these at every single one of these sites. Their job is to oversee the clinical and didactic training in that specialty and participate in grading. So what I also want you to take from this slide is that if you've got issues, if you've got problems, the student's struggling, you're struggling, you've got questions, you don't get this, these are your 2 points of contact. The LIC liaison in your specialty and the LIC director at your site. I just mentioned the one other key person in this is your clinical content director. That's the person that oversees the specialty as a whole across all of our sites. perhaps not super visible to the LIC preceptor, but they're the ones who oversee the curriculum as a whole. I should have put myself on this. I want to be a contact and available for questions as well. The LIC coordinator is perhaps the most important person. Every LIC has its own administrative person, our coordinator. This is truly the glue that holds our programs together. They manage all the schedules. If it wasn't clear from that slide where I showed you where the students go every half day, it's complicated. We have that times every single student, and then all the pieces are in constant motion. They are the ones who coordinate all the flexibility. So the piece I didn't get to is if your student's supposed to be in peds, but then they've got a really important patient to see that morning, or their patient is delivering a baby, they may contact you and say, hey, I need to move your clinic. They'll work with you. They're not going to mess up your schedule to do that, but there's a lot of communication going around constantly. They track all of our students' assignments. I think more than anything, they end up being kind of the safe space. The student has a rough day. That's where they can come and debrief and find sort of their safe space. Please communicate with your coordinators. They're constantly trying to track down our preceptors, and that will make their job so much easier. So a couple of tips for your first day. Our preceptors who can make a few minutes to meet with their student, maybe over a cup of coffee ahead of time, I think set up the year for great success. This is a time to get to know each other as people, talk to them about like some of these logistics, when to arrive, where to go, where to park. Our students are so nervous. Taking some of these logistics off their mind will make a huge difference for them. What to bring? Do you want them to wear a white coat? Anything else they should wear? What will your day look like? Give them like a little bit of a preview so they're not walking in totally cold. Do you have any specific expectations of them? What are they hoping to get from you? And then like, what's your cell phone? Or do you like to only be called or contacted by email? Those kind of things are just some ideas of things you might talk about before the first day. On the first day, there's some other things that I might think about in terms of setting yourself up for success, setting your student up for success, but also setting you up for success. Have low expectations on that first day. I don't expect them to see 3 patients and give you perfect oral presentations. Maybe have expectations only to introduce them to your team, make them feel like they're going to be a part of this team. They're there with you for the whole year. Show them around, you know, where's the bathroom? Where's the microwave? Where are they supposed to put their stuff? And then shadowing's perfect. They just need to learn the flow. I would not have an expectation of great teaching that day. Just let them learn. And then as subsequent days go on, I love to think about sort of the daily check-in. This can be 2 minutes at the beginning of each session to ask, like, what's your goal today? What are you hoping to learn? Go through your schedule. What patients would be good for you to see today? Oh, this one's really complicated and comes in a lot. That would be a great continuity patient. This one you've seen before. Let's have you see that one. This one's tough. Why don't you shadow me and watch me and give me feedback on my communication skills? I think game planning and kind of huddling ahead of time about who you're going to see can be really helpful. If you have specific expectations, like I don't want you in a room ever longer than 15 minutes, that's going to be tough for your student, but give them a fighting chance and tell them that ahead of time. Early learners could use some priming. If you just say, like, go see this patient, and you don't tell them that you want them to ask about health maintenance and follow up from their hospitalization, and oh, by the way, their sister died, so make sure you check in on how that's going. They may spend the whole time talking about their toenail pain and come out, and then you're both frustrated. So give them a clue on what you want them to talk about. Tell them what you expect in terms of notes and presentations. If you want them to follow up on labs or a consult, that's perfect. That's exactly what our students should be doing. Make that plan. And then we talked about this at the beginning, but if you want them to do some homework to read up on a specific topic or read up on charts before your next time, make that plan before you go. And then a few minutes at the end, this doesn't have to be lengthy feedback, but like, hey, let's talk about, this thing that went great, but this thing I want you to work on a little bit more next time. Those are the little bits of feedback that you have the privilege of having this entire year with a student to watch them grow. So take advantage of that. And I think these with intention can be a great daily habit. Other tips for success. We already talked about a couple of these as we were kind of going through questions as we went along. This first one I underlined here because I think it's so important. If your patient's in the hospital and it's either attached to the student, or even if it's not, this is a great way to set up continuity. So I have found that if I sit around and wait in my panel for the patient that my student happened to know to be admitted, it's never going to happen. But I have patients every single week that get admitted to the hospital, and it works just as well to tell my student, hey, Mr. Smith is in the hospital. Why don't you go meet him there, get to know him, round on him there, and then I'll make sure he's scheduled for follow-up with me on a day you're in clinic. And we can set up that continuity on the back end. So I've gotten the habit of whenever I have a patient in my panel, even if the student has no contact with them or prior knowledge, I tell them about it. This patient's super interesting. They're going to go see the endocrinologist. You should go. And that is perhaps the most effective way I have found to get my patient or my students involved in my patient's care. Helping my students identify good patients to follow. Joseph, I think you had some of the best tips around this already. I encourage you to think more about quality instead of quantity. I don't care if my patient or my student only sees one patient the entire day. If they spend all morning really digging in deep, looking up a ton of information, talking to the social worker, calling a consult, there's such rich learning there. They can spend all morning on that and learn more than they would have seen, like churning through 4 patients that are simple and they're not going to take away a lot from. I don't feel the need to fill my patient's time or my students' time with entertaining them the whole time. If I'm busy and they're sitting there, there's plenty for them to read. They can look up chart information. They have patient follow-up. Keep them busy. Tell them to do their own stuff. They can be independent in their learning. Your job is not to entertain. When I'm running around, I'm thinking out loud. So I'm ordering this because I'm thinking about this, and I need to call the cardiologist because I'm thinking about this, and I need to remember to do this. They're learning from everything you're saying. So keep running, just do it out loud. Allow your students to do as much as possible. We already talked about having them do some homework and follow up on topics they can teach you about next time. And the last plug I'll make here is for direct observation. I do not expect you to watch an entire visit start to finish with your student ever. That is the most painful and time-consuming thing ever. But what I'll ask is if you can think about trying to observe something every day, by the end of the year, you will have a really comprehensive idea of how your student's performing. So the way I've learned to approach this is at least once during the day, I try to watch the student doing something and take away 3 points of feedback. So that may be telling the student, hey, I'm going to pop in at some point during your visit when you're taking your history, and I'm only going to stay long enough until in my head, I can say 3 things that are meaningful to you. And it might be like, wow, you did a really nice job agenda setting. I wish you made eye contact more with the student. You're only staring at with the patient, you're only staring at the computer, and you used a lot of medical jargon in there. I can do that in 30 seconds, write it all down, and then the student comes out and I have something really tangible to tell them about their interviewing. The next time I can go back and do it about their physical exam. And if I do that every single day and make it a habit, the student knows to expect it. It doesn't feel like the world is ending if I gave them some constructive, maybe tough feedback, because I'm doing this constantly. But I'm observing. I'm basing my feedback on real observation. What makes a great preceptor? This is my idea of what makes you awesome. Be a great role model. Think about the fact that the student is watching everything you do. Demonstrate to them what professionalism looks like. Show them what great patient care looks like, and show them what caring looks like. I don't think you have to have an encyclopedic medical knowledge. I don't think most of us do. What they want to see is great doctoring. Give feedback, give coaching, complete your assessments of students. That's so important to us in grading. It's hard to take yourself back to that moment where the grade is everything, but the grades mean everything to these students. So help us out there. And then I think just showing that you care about them as a person and as a learner goes so far. I'm going to end here. These are a couple of additional resources. The top website here is a resource that we've created that has a ton of one-page tip sheets, basically, on kind of everything we could think about that maybe a teacher would want to know: how to give feedback, what to do with struggling learners, how to fill out an assessment. So feel free to dig into that. This is just a quick video overview of the curriculum. And then this is an article I just love every time a little bit more I read it. It's great for students, but I think it's great for faculty. It's sort of how to survive or how to thrive in an LIC. Thank you so much for your time. I am happy to, my email is here. I'm happy to entertain questions now, or have you reach out to me at any point during the year. I'd love to hear from our preceptors. And no question is too small. If you have concerns about your students, reach out. If you have questions about the curriculum, I'd love to engage around those as well. I really appreciate you coming in tonight after a long day of work to talk about the LIC.